Good morning. Can you hear me?
Yes, sir. Good morning, sir.
You can see me and hear me, right?
Yes, sir.
Okay. Can you see the shared screen?
Yes, sir.
Right. Yeah, there was a small technical issue here, so I got late by about 4 or 5 minutes. Let's start this activity. So actually, Dr. Amarnath, head of the department, wants me to inform you that let me see how many of you are here today. Now 131 participants are here as of now. That because of the prevailing situation in the country, this COVID-19 situation, and about the situation about your batch that you are about to see face a second MBBS exam, and as an institution, say University of Runa, wants our medical graduates to progress without much delay due to this activity. So probably once you are able to come physically, our intention is to have the exams as early as possible. So it's our duty to prepare you for that. And you are left with some practicals. Actually, neuroscience course, these practicals are to be done. So we have decided, actually we got the approval also from the faculty board or whatever, the curriculum development and evaluation committee, to conduct these activities online, right? So these practicals, I will be doing examination of the sensory system, and then practical on EEG, and then another practical, that is ENG practical. I will be doing. Some other staff members will be doing the series of other practicals in the neuroscience course. So these practicals will not be repeated when you come back. So therefore, get the idea. And most of these practicals are practical demonstrations. Even if I do this practical in the physically in the department during say 1 hour or whatever the time allocated for this period, about 75% of the time I will be talking, giving inputs, knowledge inputs and important concepts, and time taken for actually doing the practical is very minimal. So therefore, don't worry that you are going to miss anything. You are not going to miss anything. You will probably be better served, according to my opinion. And if the time allows, I will talk about each practical also today. If not, we will do it on another day. But we will first do on the examination of the sensory system, right? So, so when you see, when you are given a patient, when you go to third year, you will have to examine different systems, like cardiovascular system, respiratory system, nervous system, examination of the abdomen, like that. There are different areas that you have to examine. So as a tradition from the Department of Physiology, we give you some input on examination of these systems, which are actually valued by a lot of past graduates. They say sometimes even up to final year, they will not get this kind of exposure or teaching, which are really useful for the clinical, during clinical training period. So therefore, pay attention, fullest attention, and get as much as possible. Right? So you have already had practicals on examination of respiratory system, examination of cardiovascular system, and those things. And as with that, here also I want to give you some input that before you examine the nervous system, you have to have a general examination of the patient, right? And for the practical purpose of teaching, we have divided this into sensory system, motor system, and the cranial nerves, and including cerebellar functions. But when you examine a patient in the ward, you will examine and separately examine, but you will put all of them together and present to the clinician. The patient's motor function wise is like this, and sensory wise this, like that, but you take all of them together. But here today I will talk mainly about the sensory system. So as with any patient or any system examination, here also initial history taking is important. Otherwise, you will not know what you are looking for. You will have to have some idea about what you are looking for or what the patient is having. So therefore, history is important. So relevant history you have to obtain. And if there are some interesting or important things, as you see, you have to go more deep into the history part and get additional information before you proceed for examination. Then you examine the patient. As with any other system, you approach the patient from patient's right hand side. So the patient may be lying down on the bed. In that case, you must go from the right hand side, or patient may be seated up or standing up. For neurological examination, different positions are sometimes important. But before you go further, you must look at the patient and decide whether the patient looks well or ill. That is important because the nervous system includes the peripheral nervous system as well as central nervous system. Say if somebody met with a head injury, for example, and some brain damage, patient may look really ill, or somebody is having some infectious condition, patient may look ill, right? And then that is important in the initial assessment. And then whether the patient is comfortable or uncomfortable, whether the patient is comfortably lying on the bed or not, that you must decide. And the presence or absence of fever, febrile or afebrile, that is also important because it may be encephalitis, it may be meningitis, or it may be some viral neuropathy. So therefore, it is important to decide whether the patient is having fever or not. So this kind of general things you must look for. And then look at the patient's general body build, whether he is a healthy looking, well-built adult, or whether he or she is a malnourished looking person, or muscle wasting or emaciated person, or grossly emaciated, that is only bones and skin are there. These are also important because nervous functions depend on different conditions. As diabetes mellitus, maybe patient may be very wasted or severely malnourished. Vitamin B12 deficiencies and other vitamin B complex deficiencies may lead to neurological abnormalities. So therefore, having looking at those things are important, and also making a mental note of them and making a note of them in your notebook is important for your presentation to the consultant. Right? And then any obvious deformities. Say if patient is having an ulnar claw hand, you know that his ulnar nerve may be damaged. So there's a motor deficit you can see obviously. In that case, you may expect sensory deficit also, and you have to look for in that specific area, not in other area. Specifically, you must look for sensory deficit in that area. Or if the patient is paralyzed or one limb is not moving, or both legs are not moving, then you know that there is some spinal cord damage probably. So therefore, observing those things are important, because when you examine the sensory nervous system, you pay particular attention to prove that or confirm that. And also, when you examine the sensory nervous system, you have to look at the skin very carefully. Looking for the skin is important for, say, hypopigmented patches. If there are lighter color skin areas, you must make a note of them. They may be on the face or the trunk or limbs, upper limbs or back, So those areas you must look for because they may indicate some infectious condition, chronic infectious condition known as leprosy. May lead to hypopigmented anesthetic patches. Sensation may be reduced or lost over those areas. So if you see some of them, you must check for sensation. Right? So that is also important. And also, if you see such a patch, you must look for thickened nerves. Nerves get thickened because leprosy involves skin as well as nerves. So thickened ulnar nerve and thickened nerves, you must look for related nerves for nerve thickening. So those things you will learn those things when you go to do clinicals later, but you must have the knowledge component. Otherwise, you don't know what you are looking at. So that is why I am telling this, right? Okay, just remember. And then about the consciousness and the brain function status, I take it as COME, that is consciousness, orientation, memory, and emotion. So those aspects, if you don't have to spend much time, look at the patient whether he is conscious or unconscious, make a note of it. If he is not really fully conscious, earlier, like several decades ago, doctors used to tell patient is semi-conscious, or patient is stuporous, or patient is delirious. Different terms have been used to describe different statuses. If the patient is drowsy, and you call it drowsy, but somebody looks drowsy to me, may look normal to you, right? So therefore, there is a little confusion between doctors. One doctor may finish his shift and go home. Another doctor or a nurse may come, and the previous doctor had written semi-conscious. Now the patient is unconscious. You don't know what is happening. So therefore, they have developed a thing called GCS, what is called Glasgow Coma Scale. Glasgow Coma Scale. If the patient's consciousness is not well, you must go through the GCS. So it is your homework today to read about Glasgow Coma Scale, because when you go to do the appointment, when you do surgery appointments, patients may come with head injuries and other things. There is brain functions may be not fully normal. So in that case, you have to apply this Glasgow Coma Scale, which checks different things, whether he responds to commands or whether his response is verbal responses are given, or those things are given marks. Different aspects are tested and marks given, and marks are added. And if you are fully conscious, you will get 15 marks. Some aspects are missing, you may get 13, 14, or 12, 10, 9. So like that, different marks are getting. When two doctors assess the same patient independently, they may get very closely the same mark. And also that is very important to assess the progress. If the patient comes to the ward with Glasgow Coma Scale 12, GCS 12, and next day morning if his GCS is 9, you know that something is wrong. Or if the other way around happens, when the patient meets with an accident and comes with GCS 9, and few hours later, if his GCS is 10 or 12 or getting increased, that means he is going towards the better side. So therefore, you have to have some idea about GCS, right? So all these are not directly related to sensory system, but important for the patient because you are looking after a patient. And then orientation, whether the patient is oriented or disoriented. So when his orientation, you have to look for in three angles. Orientation is time, orientation in space, orientation in person, right? So orientation in time means, or rather we'll take orientation in space first. That is more important. You ask from the patient, obviously when the patient is in the hospital, if he cannot recognize it and if he says he is at home or he is in Colombo or something, like something totally unrelated, then you know that he is not oriented in space. He is disoriented in that sense. And then you ask for the time. මේ වෙලාව කීයකට ඇති කියලා දෙහිතෙන්න ලොකු නැහැ. ඒකෝට මේ රෑනේ කියලා කිව්වොත් එම දවල්ට you know that he is not oriented well. Or දිනේ ගැන අවබෝධයක් නැත්නම් මොන අවුරුද්දද කියලා දන්නේ නැත්නම් so then that is important that is oriented or disoriented. And then orientation in person, that means you ask what is your name, who are you, and then if he is telling totally unrelated irrelevant things, you know that he is not oriented. Or if he cannot recognize the doctor, you know, who do you think I am? Or if you show a nurse and ask, so that means he is not properly oriented, and you know that something is wrong. And then emotion aspect, that is emotion has to be stable in a normal person. Under normal circumstances, you do not cry, or you do not unnecessarily show happy mood or laugh unnecessarily. So if it is appropriate or inappropriate, you have to make a judgment. And also emotional stability, because a person should not change his emotion every minute this way and that way. So if somebody is smiling and happy this minute and next minute if he is crying, that is called emotional lability, emotionally labile, right? Unstable. So that is important that you assess that aspect also, right? So these are general things that you look for, and this is important for all neurological examination, not only for sensory examination, motor or cranial examination. So all these things automatically you just look at it. You don't take this much time as I took to describe this. In 1 or 2 minutes, you can look at all these aspects and make a mental note of it, right? Right. And then when you do the sensory system examination, you are required to have some knowledge component for sensory system examination, right? Because when you examine the sensory system, I mean, obviously it involves, I just omit the cranial nerve part. I will talk about the peripheral nervous system. So anything below the neck area, the whole thing you have to examine. So if you do not know what you are looking for, it is like trying to find a needle in a stack of hay. Right? It's like going blind, but it has to be, ideally speaking, it has to be targeted. If you think that is right upper limb may have sensory loss, or if you think that is spinal cord is broken, that is so much easier for you to do the examination. So it has to be targeted examination rather than blind examination. That is therefore you need to have some interesting and some inputs on history and other general examination and under what circumstances he came, right? So those things are important. And then very importantly, your anatomy knowledge comes into play here. You have to have a good knowledge on dermatomal distribution and peripheral nerve distribution, because otherwise you will go on checking randomly different places whether you feel low or not low, you know, like you will not interpret anything. But if you know where your dermatomes are, where your nerves are, supplying areas, you know where to look for. For example, the easiest thing, if you expect a radial nerve damage, you know what it supplies, the superficial cutaneous nerves and other things, but you know only this area, between the first metacarpal and the second metacarpal, only this area there is a small sensory loss in radial nerve. Although it supplies a wide area, there is a overlapping from the other nerve. So therefore, if you know that there is a fracture humerus and the possible radial nerve damage with a wrist drop, you must specifically look at this place. If you do not check this place, you will miss it and you will fail the exam. So therefore, you must specifically look for this place, and therefore you have to have this knowledge component when you examine the sensory nervous system, right? And then similarly, you must have some basic knowledge on spinal cord tracts, ascending tracts, particularly for sensor system, for motor system, descending tracts, where these things are, which part of spinal cord in a cross section, those are involved, because spinal cord damage from different areas may have effect on particular tract, and unless you have that knowledge component, you may not be able to determine what has happened, right? So therefore that is important. And then also when you examine the sensory system, you must know that there are different modalities of sensation that you look for. Say touch also like touch and good touch, the pain, temperature, vibration, proprioception, that is position sense. So different aspects are there. So you have to examine different modalities. I will come to that in a subsequent slide, a little bit more detail, why we go to examine different modalities. Why not only examine touch or temperature or pain or only one thing. We will talk about it in a minute. But is it clear as of now? මම කියන එක ඇහෙනව නේද clearly? පොඩ්ඩක් මගේ mic එකේ එහා තියෙන කැමරා එක. I think it picks the sound well. ඇහෙනවද? Okay. Right. So this is what I told you about the distribution of peripheral nerves and the dermatomal distribution. In this diagram that you see, this I took from Hutchison clinical methods. So when you examine systems, you must follow a book. So the recommended book that available, we recommended for physiology course, Hutchison clinical methods. If you buy the hard copy, you can buy the 24th edition, but on the web, you can find the 23rd edition, right? You can download it free of charge. Not much of a difference. But you must have, when you go to third year, you must have this book. Or there's another book called MacLeod's, again for clinical testing. So one of those books you need to have, and it's pronounced as MacLeod's, but written as MacLeod's, right? So that book, one of those two books you must have, and so this diagram shows the anterior aspect of a person, and this half, we get the laser pointer. This half shows the nerves. This half shows the dermatomal distribution, right? So if you take dermatomes, for example, certain things you have to remember. Not all the dermatomes you may not be able to remember, but you can work out if you have some anchors. You can remember it. So what I remember is say C4 is top of the shoulder blade, and C5 is over the deltoid area. So you can see. And then one other important landmark is C7 for the middle finger. So in anatomy you must be learning. So the middle finger is C7. So C5, C6, C7, then C8. This area is T1, this area, and axillary region T2. So T1, T2 come here. That you have to, that is important because cardiac pain is referred to radiating down the arm, because heart is supplied by T1, T2 that nerves, and same dermatomal supplies there for the inner aspect of the arm. So that you have to remember. So C7 is the middle finger, C5 here over the deltoid, C6, middle one is C7, C8, T1, T2, like that you remember. Then T10 is umbilicus. In this one, it says D. D10 is the umbilical region, and then the hypogastrium is just above the pubic line, is T12, and then in front of the knee is about L3, and then this one, the sural nerve or the lateral border of the foot is S1, and I will just go to the other diagram also, and then on the other half of the diagram, you can see nerve distribution, and in a say ulnar border is by the ulnar nerve, 1.5 fingers on this side, and then the 3.5 fingers on the other side is the median nerve, and then radial nerves involved in this area, and the back of the hand or dorsum of the hand, which I will show you in the other diagram. So like that, and then lateral cutaneous nerve is over the outer half of the leg, because these are common nerves that get damaged, and so you have to have some idea, right? And then if I go to the next diagram, you can see the back of the person. So this is the front view, this is the back side of the person. Again, under dermatomal distribution, 3 S's are important for lower limb. You stand on S1, so that means your lower part of the sole where you stand is S1. Stand on S1, you sit on S2. S2, you can see S2 here. So ischial tuberosity, those area is supplied by S2, and then you sit on S3. That means around the anus is the S3. So you stand on S1, sit on S2, sit on S3. Shit means defecation, right? So just remember some of these things, and you can see the nerves come out from here and then goes round. L2, L3 goes round and goes in front to the knee, this area. I mean, you don't have to remember everything, you have to have some ideas. If you know that L3 is here, above that must be L2, and L4 must be below that, and then L5, and then S1, the outer aspect of the lower limb, right? So, right, is it clear? So this diagram or something similar to this from your anatomy book or some clinical anatomy book or whatever, you have to get some general idea onto your head. And these distributions of dermatomes is important for assessing spinal cord damage. So if somebody is having sensation only above the umbilical level and below the umbilical level loss of sensation, you know that his spinal cord is damaged at T10 segment, right? So that is why that information is important, right? And ciphisternum area is about T78, right? Okay, so let's move. Is it clear so far?
Yes, sir.
Okay. And then I told you that you must have some idea about the nerve tracts and the cross section of the spinal cord. All these things have been covered in neuroanatomy, I know, pretty sure. So this is just a cross section. Red colored ones are the motor tracts or descending tracts. Blue colored ones are ascending tracts. So you can see this gray area is the cell bodies. This is the dorsal root. This is the anterior horn. And this is the dorsal horn. And this one is the central canal. And then you have dorsal columns, or what are called posterior columns, which is divided into mainly two, fasciculus gracilis and fasciculus cuneatus. So the cuneatus is more lateral, gracilis is more medial, right? And then another important thing is this one, in blue here, is the lateral spinothalamic tract. Most of the sensory information are carried in these two things, dorsal columns and the lateral spinothalamic tract, right? So therefore you must know where these things and how the fibers enter into this. I will show you another diagram. So we'll just forget about the motor parts for now. We are interested in sensory today. Dorsal column is two areas, and then the lateral spinothalamic tract and anterior spinothalamic tract are there, right? And because these can get damaged, and you have sensory impairments when these are damaged, right? Okay, if you look at this one, this brings to my previous topic. I told you that there are different modalities of sensation, touch, pain, temperature, vibration, position sense. Do we need to examine all of this? Yes, because we can have what is called dissociated sensory loss. Dissociated sensory loss. That means loss of pain and temperature while preserving vibration and proprioception, or vice versa. Sometimes you lose vibration and proprioception while pain and temperature is preserved. You have some aspects lost, another aspect preserved. So therefore, examining all aspects may give some idea about the patient's disease condition if you do a proper examination, right? And as you know, light touch goes in the dorsal columns, and the good touch may go in the lateral spinothalamic tract. But that distinction is very difficult, so that is why that touch is not involved here, right? It's more clear once. Pain and temperature goes in the lateral spinothalamic tract. So if the lateral spinothalamic tract gets damaged, you lose pain and temperature sensation from an area, while from the same area, vibration sensation may be preserved, right? Because dorsal roots are not damaged. So that is why it is important to examine. So you can see from the posterior root, nerve fiber center, and the proprioception and vibration sensation goes up, ascends up in the dorsal columns. On the other hand, pain and temperature may enter from the dorsal columns and ascends 2 to 3 segments and cross to the other side and ascends up the lateral spinothalamic tract. And this crossing occurs just anterior to the central canal. And there is a disease known as syringomyelia. Have you heard about this name? Syringomyelia? එකසිය පනස් ගණක් ඉන්නවා මේ නම අහලා තියෙන එක්කෙනෙක් සිරින්ගොමයිලියා අහලා නැති වුණා මෙතන ලියලා තියෙනවා නේ expansion of the central canal which damages the crossing fibers of the lateral spinothalamic tract. So at this crossing it may then get damaged, right? So the central canal may expand like here. The expansion mostly occurs towards anteriorly, but in advanced stages it can affect the posterior parts or the dorsal columns also. But initially it will affect the anterior part, and this is common. When it happens, it is more common in the cervical or the upper lumbar, upper thoracic areas. So can affect the hands, right? So expansion of the central canal affected these crossing fibers. It can damage the crossing fibers, so the pain and temperature sensation may be lost. So therefore, you must look for pain and temperature as well as whether the other aspects are preserved. You have to check, right? Is it clear? Right. Let's go. And sometimes the other way around can happen. Dorsal columns can get damaged. In that case, loss of vibration and position sense. Position sense means proprioception. Sometimes it is called joint position sense. While pain and temperature are intact, right? And it can happen in neurosyphilis, what is called tabes dorsalis. So if you do not treat a syphilis patient for years, say after many years or many decades sometimes, patient may develop what is called tabes dorsalis, where his posterior columns are damaged, so dorsal columns are damaged. And it also can happen in severe vitamin B12 deficiency. Yeah, there is a condition known as subacute combined degeneration of the spinal cord. So it's not acute, it's subacute. It's a slowly progressing condition. Combined means it affects both motor and sensory functions. Degeneration of the spinal cord due to vitamin B12 deficiency. Does vitamin B12 has anything to do with the nervous system? What does it do? Have you had any lectures on biochemistry on vitamin B12 and synthesis of something important for nerves? Is vitamin B12 important for myelin synthesis? I think so, no? Vitamin B12 is important for myelin synthesis. I think it is from, I think, I remember correct, methyl malonyl CoA to succinyl CoA. Synthesis is involved, I mean B12 is involved in that step, no? So go and read your biochemistry. It may be asked in the biochemistry exam. So when the B12 is not there, myelin synthesis is affected. So that is why the spinal cord can get damaged. And when this spinal cord dorsal columns are damaged, the position sense or proprioception sense is not there, and the patient may develop what is called Romberg sign, positive Romberg sign or positive Romberg's test. So say in this example, if around T8 spinal cord is damaged, below that patient loses loss of position and vibration sense below the level of lesion. And the Romberg's test means with eyes closed, patient tends to fall with the feet together. If he is asked to close the eyes, patient tends to fall because the dorsal columns are damaged and position sense does not go up. And for I think in the lectures you may have learned that if somebody to maintain his posture, he needs 3 inputs together with cerebellar coordination. So 3 inputs are the visual input, from the internal ear, you get some input on from the vestibular region about the orientation, and then joint position sense, whether your joints are flexed or extended, that information goes to proprioceptive fibers. So all these 3 inputs help in maintain posture. In order to maintain posture, you need at least 2 of these inputs out of the 3, 2 of them at least needed. So, so that is why a normal person can close your eyes without falling. If you stand up and close your eyes, you have the auditory input and joint position sensing input going to the brain, and that is enough to maintain your position. But if somebody does not have the proprioceptive input, what will happen? He will have visual input and the auditory input. Now suddenly if you ask him to close the visual input, he is left with only the auditory input. And that is not enough to maintain the balance. And the patient tends to fall. Right? And when you do that, you must be prepared to catch the patient without allowing him to fall down and injure himself. So that also you have to remember. And also it is known as wash basin sign. Wash basin sign. Because when the patient is going to wash his face in the bathroom, his eyes are closed and he will fall on the wash basin. Right? So rabies specialist patients can experience that kind of thing. And nowadays, rabies dosage or the untreated syphilis is rare because this syphilis spirochete, the bacterium is very sensitive to penicillin, and within most of the patients or the population gets some sort of antibiotics due to some other reasons, which may also be helpful in kind of not having this disease nowadays very commonly, but it's a very famous condition, so you have to know, right? So in the next video, we will show the Romberg's test. Just have a look at this. Get this to run, see. Right. So you saw what happens when you ask him to close his eyes, he tend to fall to one side, and you have to be prepared. Sometimes doctors ask him to keep the hands like this also, can keep the hands in front so that it will be more easily performed. And there's what is called progressive Romberg's test, where you go step by step. So those things you can learn later, but at least you must know the meaning of the word Romberg's test. That means in a patient with suspected loss of position sense or the dorsal column damage, you get the patient to stand with feet together and ask him to close the eyes. And if he sways to one side or if he tends to fall over, that is the positive test, right? If you get the patient to stand with feet together and with eyes open, if he sways this way, that way, if he's unstable, what do you think is the condition? As they arrogant in that ditwa party එකට පස්සේ නම් එහෙම වෙනව නේ දීපු මිනිස්සුන්. But do you think any condition where you are unable to stand with feet together stably?
Cerebellar lesion?
Yeah, cerebellar lesions. In cerebellar lesions, you have to have broad-based foot to maintain your balance. So, as the arrogant that's a cerebellar lesion. So, when you are with the eyes open, if you are stable, but when you close the eyes, if you tend to fall, that is dorsal column damage, right? Okay. And then I mentioned about hypopigmented anesthetic patches or hypoaesthetic patches. It may not be anesthetic sometimes. Anesthetic can damage. Hypoaesthetic, that means less feeling compared to other areas. So can you see this one? Is there a hypopigmented patch here in this picture? This can happen in leprosy. You have to have a trained eye to recognize the hypopigmented patch. That comes from our weakness. But in this one, there's obvious scar or some injury here. But if you pay attention to this whole area, the mulu area can part adu it's hypopigmented, hematic. This whole thing is hypopigmented. sometimes very subtle difference from this area to this area, but it's very, to a trained eye, very quickly it can be recognized. And I think you met, you know, Professor Somasiri, who was in our department and retired last year. He did his PhD on leprosy and nerve involvement, and so we tend to get a lot of leprosy patients to our department in 1990s for his PhD work, and he can very easily recognize that this is a leprosy patch, or we also are able to, because we have seen most of those patients. So this is a hypopigmented patch. So if you see something like this, you have to ask whether he has the same sensation or reduced sensation over this area, and then test it using your instruments, right? So I will talk about what you need for testing data, and I will show you some more diagrams. Can you recognize hypopigmented area in this diagram? You know that? Yeah, in this area, there's hypopigmentation. And also skin appendages are also less. Hair is thin or absent, and skin is shiny and atrophied. So right? So those things are leprosy, right? And there's another one here, hypopigmented area, and also trophic ulcer. Due to nerve damage, he may have got injured and this finger, but there is a hypopigmented area here. And sometimes this can happen in back or on the face. Right? The big hypopigmented patch, or sometimes smaller patches may be seen in some people. And this diagram, unfortunately, was there in the web with eyes open. So I thought it is not nice to do that, so I covered the eyes, because it is unethical to show somebody who, like with the recognizable features. So you have to close the eyes if you show it, right? So this is hypopigmented patch. And how do you test this one? දැනෙනවද නැද්ද කියලා ටෙස්ට් කරන්නේ කොහොමද? You have to get if you check the light patch, you have to get some cotton wool and make it like a wick, පොඩ්ඩක් එක කොනක් නිකන් ඌරක් වගේ හදා ගන්නවා. Then you touch it, right? And test it. I will get into more details in a minute. Or if you want to test the pain sensation, you get a toothpick, wooden toothpick. Needles are not ideal. Say needle or a injection needle or a common needle or a safety pin. Those are not recommended because you can injure the patient. So with the toothpick, you don't test the touch. You prick to induce pain and ask whether he can feel the pain, right? So therefore, slightly, not very sharp, but slightly blunted toothpick is the ideal one. So if you want to demarcate this anesthetic or hypoaesthetic area, what you do is you have to start from center outwards or from normal area inwards. What is the direction? කොයි පැත්තට බලුවොත් අහුවෙන්නේ? මෙහි ඉඳලා මෙහෙට આવද්ද? එහෙම නැත්නම් මැද ඉඳලා එළිය පැත්තට යනකොටද වැඩි වෙනවා? Any idea? 50% chance of you getting correct.
So towards the hypopigmented area, from out to in.
Going outwards? You think going outwards?
From center to outward?
Yeah.
Area
It
to
has
the
to be from
anesthetic
center
area.
to outwards, like this. From center to outwards, and ask the patient to tell as soon as he feels normally. Because if you come from here, he feels normally, suddenly he doesn't feel anything. He will not tell that he doesn't feel it. So it is very difficult for him to judge and also we to judge. So therefore, movement from center to outwards is the usual one. And also when you do sensory system examination, you should not repeat it many times. Then everything will get confused. දෙතුන් පාර කරන්න අපිට පිස්සු හැදෙනවා මේ මනසකට පිස්සු හැදෙනවා මොනවා කියනවද, right? So quick examination is important. So you move from center to outwards. Abnormal to normal is the direction. Abnormal area to normal area. Okay? And then, so up to now, you use your anatomy knowledge or whatever your neuroscience knowledge to demarcate lesions or identify lesions, because you know the dermatomal distribution, you know your peripheral nerve distribution, because with your anatomy knowledge, you are masters in that area. But sometimes patients do come with different distributions which is not falling into peripheral nerves nor to dermatomes. So this is one example. So this black area is having cell deficiency. So we call it glove and stocking, or in this example it is written as stocking and glove distribution of sensory loss. Or some people call it glove and stocking type of sensory distribution. Gloves sekai, stocking solai, so when it is mild, it may affect only the legs. When it is severe, hands are also affected. This can happen in peripheral neuropathies, what is called polyneuropathic, affecting many nerves, and these are not uncommon in patients with diabetes. So in long-standing diabetes, nerves are affected. Longer nerves are affected. The peripheral parts of longer nerves are affected more. So that is why legs are affected first, and then the hand is the next long one. Hands are affected. So this is peripheral neuropathy. This is called peripheral neuropathy or the polyneuropathy, which affects peripheries without limiting to any single nerve or any single dermatome. It affects many, and distal areas are affected. And so glove and stocking or stocking and glove type of sensory loss is experienced by patient, right? So in diabetes patients, it can happen. In old age, that can happen. A lot of old people sometimes complain of sensory loss, so abnormal feeling, not normal feeling. But you can't do much, but you must identify that this can be a peripheral neuropathy. Right? And the causes for peripheral neuropathy, you can remember it's DANG, DANG, diabetes, alcohol, nutrition, that is vitamin B complex deficiencies, and Guillain-Barré syndrome. Guillain-Barré syndrome, it's a post-viral condition where peripheral nerves can get affected, right? So this alcohol, diabetes, these things are important because alcohol sometimes lead to alcoholic myopathy also. Muscle wasting also can happen. That is why I ask you to look at the patient's body build. So that may give a clue. If you see somebody very wasted, muscle wasting, it may be diabetes or it may be alcohol or nutrition, right? So you must pick it, and also you must tell it. In an exam, if you don't tell it, you will not get marks, right? So in order to do that, you must see normal people, how a normal person would look like, how this type of person would look like, right? So, and then another diagram just to show the polyneuropathies can affect distal areas, whereas mononeuropathies can affect single nerves. The common peroneal nerve compression, site of compression is the fibular head, and you lose sensation in this area. Or ulnar nerve damage, you lose sensation in the 1.5 fingers in the ulnar side. For the median nerve here, radial nerve in this area, plus at the rib here, right? So like that, common nerves you must know, but peripheral neuropathy is not related to any special nerve distribution. It's glove and stocking type of loss. Right? And then, how do we test different sensations? And this is the part that we do in the practical. Actually, we have these instruments and the equipment needed that we get a student tested. That is all what you are going to miss today, but you can imagine what it looks like. So it has to be touch, pain, vibration in that order, because I think actually I got this diagram together, those three pictures are together in one diagram from the internet, but I cut it and changed the order, because in that diagram, pain test was the first one to be demonstrated, which I think is threatening. When you get a needle or some sharp thing and try to induce pain and ask whether the patient feels pain, patient may become uncooperative because it is a threat, pain. So therefore, pain should be done later. First one is the light touch. So you get a cotton swab, pulung kalla karagena, mana poda kulkala wage, and then you demonstrate what it looks like or what it feels like first. So assume that you think that there is an anesthetic patch in the hand. You don't check that first. You get the swab and put it on the face or somewhere. You tell, when may wage danenne කියලා then අපි බලමු මෙතනත් ඒ වගේ දැනනවාද කියලා. Then you go to hands and you test the normal areas first according to some dermatomal distribution or nerve distribution, because otherwise අර එහෙම ඔබ ගියොත් මොකක්වත් හිතා ගන්න බෑ. So you look for C5 area, C6 area, C7 area. If all that is normal, you are fine. Then go for C8. If it says it doesn't feel this area, it may be ulnar nerve damage or C8 damage, right? So and then come up and see whether there is ulnar flow hand and other things put together, and you come to some possible diagnosis, right? If it is C8 and below, if you cannot see, you feel C8, T1, T2, you know that there is some spinal level damage. It can be a complete damage, or it can be heavy section, or like Brown-Sequard syndrome. So you read about Brown-Sequard syndrome. Those are famous anatomic topics. And you go on touching with a cotton swab, and then move to the other side of the body and check that area, and then lower limbs and the trunk in a proper order. You check and make a note of it. And same areas, then you get a toothpick and prick, not to injure but induce pain. And ask whether it's painful. And if there is some, he says, when you compare it with a normal area, whether you feel the same feeling or different. So if he feels, but to a lesser degree, it's called not anesthetic area, it's a hypoesthetic area, right? So, so that is how you do it. And then vibration test, you get a tuning fork and get it to vibrate by hitting it on the palm of the hand without making much noise, because you can test this, because sometimes our patients are not very cooperating. Right? So vibrate negative, but they tell then vibrate, right? So without vibrating, you can keep it sometimes, and so you vibrate and keep it and ask whether vibration is felt, or you just to check whether he is reliable, you can keep it without vibrating and ask what do you feel. Then he says, good, right? So one important thing, you cannot use any tuning fork. You have to have, ideally speaking, lower frequency one, not 256, not 512, but 128 hertz is the recommended one for vibration sensation. Very easily you feel the vibration with this one, the 128 hertz tuning fork. And when you vibrate the tuning fork, do not hold from the arms, hold from the handle. Vibration stops. So therefore you hold from the handle and keep it on a bony prominence. Bone starting from distal area, you may move upwards, you may keep it over the medial malleolus or tibial tuberosity, because sometimes if it doesn't feel this area, then go for this area and see whether he feels it. That means only very, very distal areas are affected. If it doesn't feel this area vibration and vibration from this area also, that means it's more extensive loss of vibration, more severe loss of vibration. Tibial tuberosity at the top, large in noise, right? Okay, so that is about vibration sense. And then continuing on testing different sensory modalities. What is this? This is joint position sense, or what is called, some books call it position sense, some books call it proprioception. That is idea about the position of the joint, whether it is flexed in a resting position or extended in the other direction, right? So to do that, you must follow, you must tell the patient, while the eyes are open, you show the patient, if I bend it like this, right? So you tell the patient or you teach the patient, this is what I want you to tell. Right? And then so demonstrate what is downward movement and what is upward movement before the beginning of the test while patient watching. And then instruct to look away or close eyes. And this is important. What do you tell the patient? To look away or close eyes. Any sensory modality, you have to do it. Hypopigmented patch so so which one you prefer? What do you think? Is better? අපේ හොරු ඉන්නවනේ ආක බලන්න හොරාට බලන්න එහෙම බලන්න මෙහෙම ආක බලනකොට ඔළුව උත්තර කරගෙන මේ පැත්තෙන් බලනවා ගෑවෙනවා. What do you think? She is correct. It's better if the patient can look away, because when you close the eyes, old books, new Hutchinson doesn't tell it, but old Hutchinsons used to tell that it will tend to make your sensorium dull. You feel sleepy. As they go සංවේදී භාවය අඩු වෙනවා. Your response rate may not be as good. So therefore, it is better if alertness is more if the patient keeps his eyes open. Right. So you ask the patient to look away and then test on the area of interest and instruct to look away or close eyes. Not only for position sense, sensation බලනකොට vibration බලනකොට touch එක බලනකොට ඕනෙකට එහෙම කරනවා නම් better. But if the patient is not reliable, you can get people be more to close the eyes and stabilize the limb with one hand. මේ කාතකින් හොඳට අත අල්ලගන්න විතර හරි එන්නේ. Then grasp the area to move from sides and move up or down. Hold from sides and move up or down. Why holding from sides? Yeah. If you do this, this is wrong. If you do hold from sides, that is correct. Why? When you move up or down like this, with the first diagram, like this. What happens is, as opposed to this one, when you do this, the interphalangeal joint, either flexors or extends, he has to feel it from the joint position sense. When you do this, in addition to joint position sense, you are giving some sensory input, touch input or pressure. The ball of the thumb will, or the big toe will be pressed from below. But from side, you will not feel it. But if you do this, the patient can, even if the joint position sense is not there, he can tell that this is going upward or downward because of pressure effect. So it is always better to hold from the sides, right? And patient has to tell whether it is moving up or down. A normal person can easily tell it, right? Whether it is moving up or down. And light touch, as I told you, is tested using cotton swab, like pointed a little bit, and you test according to dermatomal pattern, according to nerve distribution pattern, because otherwise you may not be able to interpret, right? So you go in a certain pattern, and again there are important practical points. Demonstrate what it feels like on a normal area. Example, on the face, so the forehead or somewhere. Then ask to look away or close eyes, and look away is better. Yes. Ask the patient to count 1 if he or she feels it. If he or she feels it again, to count 2 and so on. මේ ගෑවෙනවා දැනකොට එක කියලා ආයෙ දැනනොත් දෙක කියන ආයෙ දැනනොත් තුන කියන එහෙම දිගට ගණන් කරන්න. So patient will tell 1 2 එක දෙක තුන කියලා එහෙම patient කියන. But as the examiner, you have to be smarter than the patient, because you do not touch at regular fixed intervals. If you every 1 second if you touch an area, දැනෙන්නේ නැති වුණත් patient 3 කියනවා, දැනෙන්නේ නැති වුණත් 4 කියනවා. ඒකෙන්ද නිකන් ගාවන්න වගේ කියන ගාවන්න නැතුව නැවතිලා බලන්න. ඒ 3 කියනවනම් patient is unreliable, right? නිකන් අත ගොල්ලලා සද්ද නැති වෙනවා ගාවන්න නැතුව, right? So you move the hand but don't touch, and patient will should not count in that case. And then you go at irregular intervals and like unpredictable intervals, you touch and see whether the patient's response is reliable, and then you make a note of his response. He is not sure of some areas. If he is not sure certain areas, you compare. Okay? Do it in such a manner to locate dermatomal deficiency pattern or peripheral nerve lesion pattern. On suspicious areas, when he has some sensation, body sensation make a comparison with the normal area and ask whether the feeling is lesser or similar. So if it is lesser, you call it hypoesthesia, not anesthesia, right? And then temperature sensation, because as you know, pain and temperature are involved in lateral spinal thalamic tracts are involved. So if there's lateral spinal thalamic tract damage, like in syringomyelia, crossing fibers are damaged, this sensation testing is important. You get 2 test tubes, one with cold water, one with hot water, and when the tubes are prepared, you cannot waste time. You have to quickly do it, because otherwise they will equilibrate and come into room temperature. If you leave it for half an hour, when the tubes are ready, you must perform the test, right? And tubes can be labeled, you can feel it. Hot water, cold water, another tube should be there, and it's warm water and cold water. So cold water should be about 4 degrees Celsius, or ice water is okay. Warm water, it should be around 45 degrees, or 43, 45, this area, just above the body temperature. Not hot water. So if you get near 100-degree water into a test tube and put it, patient will feel it even if it doesn't have temperature sensation because of pain, right? So therefore, it has to be warm water, and the expected normal finding is that patient should be able to discriminate warm from cold easily, right? Without much difference, he will give the correct response whether it is cold or warm, right? And then about touch sensation, few additional things here. When you examine the touch, light touch, in the clinics, sometimes even in diabetes clinic in Karapitiya hospital, teaching hospital Karapitiya, they do this test, what is called nylon monofilament test. So there are, we have in our department not this colorful, but metal bar with a nylon filament, right? Metal bar with a nylon filament of different diameters. So this is a very thin one, thicker one, even thicker, fairly large fiber, and a very, very thick fiber, monofilament, right? Nylon monofilament. Monofilament කියන්නේ එක මේ braided එකක් නෙවෙයි, අර ගොතපු එකක් නෙවෙයි, තනි කුට්ටිය වගේ තනි જાතිය fiber එක, තංගුස් මූල වගේ, right? And so what we do is we get the patient, and these are numbered, number 1, 2, 3, 4, 5, 6, like that, and we ask the patient to look away and ask whether he feels it by keeping it in a lower limb or lower part, peripheral part of lower limb. And if he sees it, we know that patient sensation is good if he feels that even the thinnest one. So somebody diabetic peripheral neuropathy may not feel the thinnest one, may not feel the next one, may feel only the third one sometimes. So generally now diabetes mellitus clinic in Karapitiya, they get down patients every year for these special tests. And say somebody who feels only the third one this year, when he is being tested next year, he feels only the third one, that means his condition has not become worse. It remains the same. If next year he cannot feel the third one, but he has to go to a higher one, bigger one, fourth one, that means his condition has got worsened. His diabetes control may not be good. Right? So peripheral neuropathy is getting worse. Sometimes even if you control it may get worsened. But is it a subjective evaluation or objective evaluation? What is the difference between subjective and objective evaluations? It is not subjective, it is objective. No, it is because judgment we measure something and write it. It's like an MCQ. MCQ is an objective assessment, whereas essay paper is a subjective assessment. Right? See, if it is not true, it will be true always, right? So, so like that is the objective assessment of touch. Right? You take monofilaments, right? And this instrument is called tensiometer. Tensiometer. So that is something that can be quantify the touch sensation. This nylon filament. I have seen certain things with the digital ones. Right? So, but those are too sophisticated. A simple one like this is good enough. And then vibration sensation, as I told you, you have to use tuning, vibrating tuning fork. This is correctly held, not touching the arms. Arms are basically vibrated. So holding from the handle, and real tuning fork should have a broader base, flattened base like this. for this purpose, so that is better. This is not ideal. It's not broader based, but there's nothing. This also is good. And here again, you start from a peripheral area, the most distal area, starting from a finger, 2A. 2B diagram is the side of the wrist over a bone, and then 2C over the elbow. Right? So you go up and see whether he is only having loss of sensation in the distal most part, or whether it extends here to over here, which indicates more severe illness. Right? Right. And this one is the most advanced part of this one, this practical, that is cortical sensory function. So what is called cortical sensations, testing cortical sensations, or what is known as interpretive functions in the parietal lobe, because your sensory input goes to the parietal lobe and is interpreted. Right? Sometimes there may be a stroke or some deficit in the parietal lobe, which will affect the interpretation function. Right? But if you examine his test, sensory modalities in periphery, each one will be normal. He is feeling pain, he is feeling touch, he is feeling vibration sensation, he is feeling warmth, he is feeling proprioception. Everything is intact, but interpretation may be affected, and we call them higher cortical functions. So the cortical sensory functions, which are tested in if all the others are normal, you can go for this, but don't tell this as the first thing when you go to do clinicals. If you tell this as the first thing, what do you test for sensory? If you test stereognosis, your consultant will not be very happy. You must tell, I will test the pain sensation, or I will test the touch is the best one to start with, touch sensation, and then go for pain, temperature, vibration, and proprioception. We'll finish that, and then you can move to higher cortical functions where you look for certain things. This one, first one, what is called stereognosis, means the ability to recognize common object with closed eyes. You ask the patient to close the eyes, and then you grab something from your pocket, say, key or a clip of a pen, common thing. Common මොකක් හරි මේ ඉස්සරේ මේ පිරමීඩයකින් හොයාගත්ත පුරාවස්තුවක් වගේ මොකක් හරි ගතිය මේක මොකක්ද කියලා අපිට කියන්න බෑ. So give something common to his hand while eyes closed and ask him to identify. So coin, කාසියක්, right? රුපියල් 5 කාසියක් වගේ දුන්නා. අnder කෙනෙක් රුපියල් 5 කාසියක් කියනවා කියන්න පුළුවන් වෙනවා. නේ ටිකක් ගන්න අමුතු જાතියක්. අනිත් කාසිය නම් දැන් එකක්වත් බැලුවත් අඳුරන්න බෑ නේ. කාසිය කියන જાතිය වල ඇති නේද? as they අරවත් අඳුරගන්න බෑ. Right? So so that is what you do. You ask the patient to close the eyes and give something common object and ask what it is, and he should be able to tell it, and that quality is known as, that ability is known as stereognosis. Stereognosis, where patient recognizes the shape, maybe the texture. So you can give different things. You can give sandpaper, වැලිකොලයක් දීලා මේක මොකක් වගේ දෙයක් මොකක්ද texture we should be able to tell, or a silk cloth, silk රෙද්දක් දීලා තෝ මේක හරි satin රෙද්දක් මේක සිනිඳු රෙද්දක් කියන්න පුළුවන්. Right? And the size, whether it's a small one, big one, he should be able to recognize, and the weight. So all these things will put together using the past experience and using his the parietal lobe functions. He will make an interpretation of this is a key. Keti මේකේ නමක් කොටලා දිනනවා, මේක රව මහිලක් විතර දිනනවා, දැටි ටික දිනනවා මේකේ යතුරේ, so that he knows that it's a key. And so like that he makes interpretation. So if the cerebral cortex is damaged, he can feel it, touch. If you make a diagnosis, yes, but what is he feeling? He may not be able to interpret if the parietal lobe is damaged, right? So that is called, if he cannot recognize it, we call it, he is having astereognosis. Astereognosis, this term. And then another aspect is have to recognize pointer or number written on palm. Forearm is closed. සාමාන්‍ය කල්ලේ ලියන්නේ forearm එක ලියුවත් පුළුවන්. If you write on the back, it may be difficult for him to recognize. පිටේ ලියුවොත් අඳුර ගන්න පිටේ nerve density is not enough. Very far away, difficult to recognize. But palm or hand, the forearm, easily you will recognize. And that ability to recognize common letter, අපි තුමු පහේ ඉලක්කම ලියුවොත්, he tells it's number 5. It's called graphisthesia. Graphisthesia means ability. Anesthesia can දැනෙන්නේ නැති එක. Aesthesia means දැනෙනවා. Graphisthesia means graphic thing that you wrote, he is able to recognize. Or if he is unable to recognize what you wrote, he is called graphanesthesia. That's graphisthesia or graphanesthesia, whether it is present or absent. And then ability to recognize two simultaneous touch stimuli applied on skin as two. දෙකක් තිබ්බොත් මේක දෙකක් කියලා කියන්න පුළුවන් නම් that is called 2-point discrimination. 2-point discrimination, again another cortical function, and it is expressed in centimeters. He has the 2-point discrimination in the dose of the hand, which is 0.5 centimeter. Normally in the hand, you should be able to identify 2 as 2, only maybe 1 or 2 millimeters apart because of nerve density. Millimeter දෙකක් විතර හැක් තිබ්බත් ටක් ගාලා දෙකයි කියලා කියනවා. ඊට වඩා කරකයි කියලා කියන්නේ. But if the patient is unable to recognize even when it is 3 centimeters apart, whether he tells it as 1, then you know that 2-point discrimination sensation is gone, right? And then there's another interesting thing, that is what is called sensory extinction or what is called sensory inattention. Sensory extinction, I will show you some pictures before I finish. That is ability to perceive a sensory stimulus when corresponding areas on the opposite side of the body are stimulated simultaneously. That means you stimulate both sides. You test touch here, patient is okay. You test touch here, patient is okay. So that means his peripheral nerves are carrying and it goes to the brain and it is recognized as touch. But if there is some specific damage in the certain areas of parietal cortex, when you touch both corresponding areas together, patient prefers only one side. එක පැත්තක් විතරක් දැනෙනවා අනිත් පැත්ත එක දැනෙන්නේ නැහැ. patient කියන දකුණු පැත්තේ අත්‍යධික බව විතරයි දැනෙන්නේ. අනිත් පැත්තේ දැනෙන්නේ. But if you remove right hand and only feel the left side, he will feel that. Individually, he will feel both sides. But when you put together, one side is extinct. One වෙලා ගියේ පැත්ත නැහැ. Right? Sensory extinction or sensory inattention. So that is also happening in certain neurological conditions. So I will show you some examples now. But the most important thing is that in order to perform cortical functions, individual peripheral sensations must be intact. අපි හිතමු මේ අල්ලන එක ඩැමේජ් එකත් obvious පේන මිනිහෙක් කියන්නේ අතට මොකක් හරි කියලා මොකක්ද කියලා අහුවට you cannot stereognosis is not there or the median nerve damage. So obvious peripheral nerve damage, you are not attempting these things, right? If it's all the peripheral testing are normal, you can go for this one. These are actually postgraduate level of knowledge, but nobody will probably teach you. So you better know them from now onwards, because otherwise, when you go to higher and higher levels, they assume that you know, but nobody has told you, and you will have some deficiency in that area, right? Okay. Let's see about cortical sensation. So stereognosis is this: you give a key or something to his hand and ask him to touch and tell what it is. As දෙක වහගෙන මේ කට මත ගාලා මොකක්ද කියලා කියන්නේ. ඕ බැලි කඩ දහියක් තියලා මොකක්ද? ඕ බෑග් එකක් ඇතුලෙන් අත දාලා මොකක් හරි අරගෙන ඒක මොකක්ද කියන්නේ, right? So something like that you can do. What is this? This is graphesthesia. You write something on his palm and ask him to recognize. Actually, you don't have to write it. This is just to demonstrate. And clip එක වහලා තියෙන එක පේනවද මේකේ? This pen clip is closed. මේ නිකන් අඟල තියෙන්නේ ඔයාලට පෙන්නන්න ඕනේ. So even with a closed clip, when you draw it, he should be able to tell you. You don't have to destroy his hand by writing different jump on his palm, right? So you write it from the back end of the pen if you want, or with a closed clip, and he should be able to recognize, right? But it has to be a common character, right? Greek, pi, hari makari, letter kali atau apa kita kan ben, ko signal akurat hari makari basic kan signal kali orang Ryan, ini lagi makari. English letters E, S, right? So five number. So that is ability is graphesthesia, inability is graphanesthesia, right? And then 2-point discrimination, you have to have a compass. You know, what is called 2-point discriminator, vernier caliper, you know. We have one in the department, actually tells you the number of millimeters apart. Millimeter kiyak සූදු දෙක ඇත්තලද කියලා බලන්න පුළුවන් එකක් තියෙනවා. So that is the 2-point discriminator, right? Where you keep it and ask whether you feel like it has 2. If he says මෙහෙම තියෙද්දි 1 කියලා කියනවා මේක තව සුට්ටක් add කරලා කියලා බලන්න. Then you measure how far apart he recognizes it as 2 and make a note. He recognizes 2-point discrimination only at 5 millimeter apart points, right? Both are same thing. And then the sensory inattention or sensory extinction, where you give same touch stimulus to corresponding parts in both hands simultaneously at the same time. So if his parietal lobe is not working properly, he will tell, he has forgotten, doesn't see, right? This can happen to vision also, right? Sensory inattention. Right? Occipital lobe is affected, right? And here also, same thing, sensory inattention. The doctor is trying to touch his forearm at the same time and ask whether what he feels, right? So there is sensory extinction or sensory inattention. අවධානයක් නැහැ ඒකට again. The 2-point discrimination, same thing in bigger manner, right? So that will end the this session. I think I will not do the EEG one today. I will schedule another type of EEG practical. It may be too much for you. And how do you feel? Did you gather any input? හරිද? ඔගේ chat එකේවත් දාන්න මොනවද ටිකක් feedback එක මම වහන්න ඉස්සෙල්ලා. Give me some feedback because this is the first of our experience on trying to attempt to conduct a practical. I believe I delivered enough content to you and enough kind of exposure to you so that you can do it, right? So and there's nothing to worry. Same thing that I told you, you have to put it at this. Maybe you can do it in somebody at your household. Test kala බලන්න කියන ඇස්වාව කරමු. And so give me some inputs. I request from all of you, just type in something and so that we can have some idea about whether it is successful or not. But officially we have decided to go in this manner because otherwise we will not be able to finish your course and get you ready for assessments. And when you come back, get ready for 2 or 3 assessments together, right? So one neuroscience assessment, I think histology assessment is there, then the second MBB is there. Right? So they will come in one after the. So get ready, study and do. Correct. I'm chatting it. Under that, I'm going to balance. Attack power. Dan lagi no dan ini balan nabai. Pasti balan. You type whatever it is. Mga aga balangin. May pakai balangin ako no. Sensor in attention. So, do you have any other online teaching going on these days? Biochemistry, so I know. Anatomy? I will try to schedule EEG practical tomorrow, and we will try to give you as much as possible. EEG also very easily can be done using online. Anyway, I used to do a presentation for EEG practical class. I have it with me. I may make few modifications to that, so it can be directly used without much problem. Yeah, with regards to seeing equipment for this one, actually, what you equipment wise, I mean, some of the things are cotton soaps, cotton wool, you know what it is. Toothpicks, you know what it is. Tuning fork, you know what it is. But other 2-point discriminator and the nylon monofilaments, you may not have seen, but you know now what it is. We will give you anyway before the second MBBS. Generally, we do what is called instrument exposition. Have you heard the term exposition? Sacred tooth relic exposition. Okay. Body exposition. Exposition means production. That means in the lab, we will give you say 2 hours, 3-4 hours session for you to come and have a look at all the instruments that we have used from your first term. That means a Westergren tubes, Winthrop tube, in case if you've forgotten, some perimetry charts and different things. We will leave it on the tables in the laboratory, and you can, as groups, come and just have a look at them. So we will put these instruments also. Some ECGs, JVP recordings, and different things, we will put them. So instrument exposition day is generally given. So this year also, we will give that before the test, right? So that you will get to see the instruments, right? Okay, guys, I got like 29 messages, so I think probably I still typing or finished. Right. So we will stop there. I will have a look at the chats. I am still typing. I will give you 1 more minute to type anything.
Thank you, sir.
Okay. You're welcome. Those who want to leave can leave.